aspiration of gastric contents is an anesthesia-related complication that carries significant morbidity and mortality. Current prevention strategies rely on asking when the patient's last meal was, history, and recommended fasting periods. Certain conditions or situations can preclude the NPO guidelines use or decrease its sensitivity. Gastric ultrasound is a simple and non-invasive diagnostic tool to clinically evaluate aspiration risk. Gastric ultrasound is indicated in any clinical scenario where the presence of gastric contents is uncertain. The equipment needed to perform the scan is an ultrasound. For an adult, a low-frequency, 2 to 5 MHz, curvilinear probe is used in the abdominal setting. For children or patients less than 40 kilograms, a high-frequency linear probe is used in the vascular setting. The scan is performed in both the supine and right lateral decubitus positions. Of note, the right lateral decubitus is the best for interpretation. Gastric contents are able to gravitate down to the antrum and air can migrate up to the body of the stomach. Scans done in the supine position alone will underestimate the amount of gastric content.
To perform the scan, you will begin with the patient in supine position. Choose the curvilinear probe and place it in the abdominal setting. Apply goo. Ensure the probe indicator is towards the head longitudinally in a sagittal plane. Place the probe just below the xiphoid process. Sweep the transducer in a left to right or an up and down manner along the subcostal margins. The patient should now be placed in the right lateral decubitus position. The steps performed in the supine position will be repeated.
Key landmarks must be identified to locate the antrum. These landmarks are the left lobe of the liver, which is anterior to the antrum, the pancreas, and the aorta, which are posterior to the antrum. When scanning the stomach, there are 4 types of antral contents that may be encountered. These are empty, clear fluid, early solid, and thick fluid late solid. An empty stomach means that there are no contents noted in the gastric antrum when the patient is in both supine and right lateral decubitus position. You will see a small, compressed antrum approximately 2 to 3 centimeters in size. The antrum will be round or ovoid in shape. It can have a bullseye appearance. At times, the ruggie of the stomach can be seen. Solid contents in the gastric antrum indicates a full stomach, and therefore a higher risk for aspiration. There are 2 different views you may observe with solid content. 1, early solid, where the patient recently ate. Or 2, late solid, an hour to 2 after the patient ate the solid meal. In the early stages, the gastric antrum will be distended and a thin muscle wall observed. Due to the consumption of food and air when eating, there will be a mixed ecogenicity giving a frosted glass appearance. This blurs the posterior wall and deeper structures on the ultrasound, making them harder to appreciate. In the later stage, content in the antrum will either be heterogeneous or homogeneous. A heterogeneous mass is indicative of solid food, while a homogeneous mass is associated with dairy and thicker fluids, such as a smoothie. Fluid in the stomach appears anechoic, or black, or apoechoic. The antrum will be rounded and distended. Walls will be thin due to the increased volume within the stomach. Fluid provides an enhanced view of deeper vascular structures. If fluid was recently consumed, a starry night image can be appreciated. The antrum will be apoechoic with white air bubbles.
Observe the antrum inferior to the left liver lobe tip. It is in an empty state with a thick muscular wall. Watch the antrum enlarge as the patient drinks water. As the water settles, it will take on the classic starry night appearance. That concludes our video on the introduction to the gastric ultrasound examination. Thank you for your attention.